We pray for Kenya as well, Lord, that you may protect us against it and give us the wisdom on how to prepare best in case of any eventualities. We pray for a fruitful meeting and for you to guide us back safely to our various destinations. It is in Jesus' name I do pray and believe. Amen.
Thank you, Michelle. Dr. Amoth, it's good to have you this morning. Thank you so much, members. So we'll just go straight to the agenda. We'll have quick introductions. Please kindly let us know who you are, the organization you work for, and Michelle, because you have the mic, with that from that corner, and quickly, because of time, from that corner kindly. Thank you, Michelle.
My name is Ayub Shafat Dwale. I work with UNICEF Kenya as Social and Behavior Change Communication Officer.
Good morning, everybody. My name is Dr. Abubakar Badawi. I work with DDSR. Thank you.
My name is Florence Yonga. I work with DDSR.
My name is Siva DDSR.
My name is Pris Kanjio from Disease Surveillance and Response.
Good morning. My name is Ken Wekesa. I'm from UNREF Health Africa.
Margaret Moraive, TV47.
Hello, my name is Helen Aura from NTV.
My name is Dr. Mark Nanyingi, Global Health Security Agenda, FAO Kenya.
Yeah, good morning, everyone. My name is Dr. Samuel Kadivane, coming from the Division of Disease Surveillance and Response, Ministry of Health.
Good morning, everyone. I'm Nasara Juma, Zoonotic Disease Unit.
Good morning, everyone. I'm Nicholas Lagat from Ministry of Health, Emergency Operations Center.
Good morning, everyone. My name is Michelle Sagala from Port Health Services, Ministry of Health.
Good morning, everyone. My name is Mercy Chepto, Division of Disease Surveillance and Response, Ministry of Health.
Good morning, everyone. My name is Caroline Maina from the Ministry of Health.
Good morning, everyone. I'm Adam Haj, WHO Kenya.
Good morning, everyone. My name is Abdulrazak Mohammed, Disease Surveillance and Response.
Good morning, everyone. My name is Victor Martini, Division of Disease Surveillance and Response. Thank you.
Zainab Mohammed, TV47.
Tabi Rotich, Radio Citizen.
Judith Omondi, Ramogi TV.
Mary Mwoki, Citizen TV.
Good morning. My name is Ben Kirera. I'm a news reporter, K24 TV.
Magdalene Saya, Red Africa Group.
Mangi, KNA.
Good morning, colleagues. DG, I'm Josephine Odanga. I work with UNICEF Kenya Country Office. Thank you.
Good morning, everyone. Caleb Chemirmir from Kenya Red Cross, Public Health and Emergencies Lead.
Good morning, everyone. Duncan Mwangi, TV47.
George Wadago, Switch Media.
Good morning, everyone. Robert Bet, WHO Kenya.
Faith Mwende, Baitu FM.
Good morning. I'm Emmanuel Kipkoech, Kenya News Agency.
Good morning. My name is Jemima Mokisha from WHO.
Good morning. My name is Dr. Nasri Omar, Division of Mental Health, Ministry of Health.
Good morning. I'm Were Ian from Ministry of Health, Office of the Director General.
Good morning.
My name is Dr. Daniel Langat, the head of Department of Disease Surveillance.
Susan Mutua, Department of Public Health.
Dr. John Kew, head of labs at the ministry.
Dr. Kungo Emmanuel, acting head, Division of Disease Surveillance and Response.
Francis Kuria, Public Health.
Okay, thank you so much for the quick introduction. We are still, okay, go ahead.
Oh, good morning, everyone. I'm Dr. Irungo Kamau, Division of Patient and Health Worker Safety, Infection Prevention and Control Program.
Good morning, everyone. My name is Dr. Rebecca Kiptui, Universal Health Coverage Secretariat, Ministry of Health.
Thank you. The rest of the members I'll be able to introduce as we go along. So thank you, Priska. DG sir, I think we'll be inviting few people from few organizations before you. So we have a colleague from the Kenya Red Cross Society, Caleb Chemirmir, just to give a remark, followed by Josephine Odanga from UNICEF, Dr. Mary Beth Maritim from University of Nairobi. We'll have Ken Wekesa from AMREF, and finally, Dr. Shem Kipton. So my brother Caleb, please, I'm giving you the mic. Karibu.
Good morning once again. Good morning, DG, all guests, partners, the media that are here with us. It's a pleasure to be with us this morning in this press event led by our DG. And I'll be brief as regards Kenya Red Cross role in terms of public health and emergencies. We have been mandated by the law through an act of parliament to be auxiliary to government, and therefore through this role we are part of this media event and all other public health and emergencies events in the country, in the past and looking into the future. More so looking at supporting the county and national governments in terms of community level actions and supporting capacity building of the healthcare workers at the county, especially at the lower levels. So it's a pleasure, Bonadiji, to be here with us and looking forward to your briefing. Thank you very much.
Let's appreciate Caleb. Thank you so much, Caleb. DG sir, as we invite Josephine to let you know that at the county level, the POEs, they are following this event virtually. So we are so privileged that at least we have gotten support from our partner, AMREF, to ensure that on Switch TV, to ensure that we have all our stakeholders following this event. So let me invite Josephine from UNICEF.
Ladies and gentlemen, all protocols observed, a very good morning to you all. On behalf of UNICEF Kenya Country Office, I wish to indicate that we are a trusted partner of Kenya Ministry of Health, unless DG wants to say otherwise. And I just wish to indicate that, colleagues, we are here really to partner as the UN, part of the UN agencies, really to work with the government and ensure that in the event that we have an Ebola virus disease, we are able to optimally, starting with preparedness, which we've already started under the leadership of DG, Ministry of Health, and be able to optimally respond. And by so doing, really our focus is to cushion our communities, children, women, and of course the men not to be left behind, really to ensure that they are minimally impacted by the effect of Ebola virus disease. Why do I say this? Because we have porous borders across Kenya, Uganda, and of course other countries. And so really for us is to ensure that we rally behind the government and ensure that we are able to have our communities really be able to detect if there's any rumor and have a strong linkage between communities and the health systems. Just to share with you that UNICEF has comparative areas of advantage. We've worked with the Ministry of Health, as I indicated earlier, basically to support in development of the Ebola virus disease contingency plan. And our areas of comparative advantage is risk communication. You can see the media here. That's part of UNICEF's comparative advantage. Another area is basically the logistics supply procurement systems. And most importantly, the area of advocacy. So we work very closely with the Kenya Ministry of Health to ensure that we are able to have optimal coordination mechanisms. And of course, well aware that WHO is the technical lead when it comes to matters health. And so UNICEF's role is basically oversight in ensuring that coordination takes place optimally. As I conclude, I just wish to indicate that we look forward to government, Kenya Ministry of Health, really leading us and ensuring that we are able to, if we got a case, God forbid, tomorrow, we are able to optimally manage this case and really protect our country. To the media, we look forward to you really basically to sell us, market us positively, and ensure that we are not able to talk issues that are different from what media is talking about. Thank you so much.
Thank you so much, Madam Josephine. So we've had a very good working relationship with the University of Nairobi. So join me to invite Dr. Marybeth Maritim. Karibu Daktari.
Good morning, everybody. I think I have to use both. My name is Dr. Marybeth Maritim. I'm an infectious disease specialist from the University of Nairobi, and I'm really happy to be here. All protocols observed. The University of Nairobi is a training institution, is the oldest training institution in this country. And our expertise really lies in training, but we also have worked closely with the Ministry of Health, even during the COVID pandemic, to sensitize healthcare workers in terms of the evolving outbreak and to build their capacity. So in this Ebola virus disease response, we envision that the university will still continue to support the Ministry of Health closely in terms of training and sensitization and building capacity for healthcare workers. And we were very successful in COVID-19 because we were able to deploy a virtual platform which is able to reach a lot of healthcare workers, and we clearly demonstrated that all the healthcare workers were keen to learn even as they served in their various capacities. Within the University of Nairobi, we also have a lot of other experts that will go a long way in complementing the Ministry of Health. We have infectious disease specialists, we have virologists, we have immunologists, and this will really be available to support the ministry in terms of providing technical guidance as we face this new epidemic. We're watching the figures closely, and we really need to be prepared because it's just next door, and the presentation is not what people typically think about a bleeding patient. So we really need to be, all of us, aware and have that index of suspicion so that we can pick the cases should they arrive within our borders. So thank you very much. We look forward to a very fruitful partnership. Thank you.
Asante sana, Dr. Marybeth. Now we'll invite Brother Ken Wekesa. Ken Wekesa and AMREF. We're here courtesy of AMREF. Thank you so much for supporting this event. Thank you, the hotel, for hosting us. So my brother Ken, karibu.
Good morning, everyone. Thank you. My name is Ken Wekesa. I'm the Communications Officer at AMREF Health Africa in the Department of Water, Sanitation and Hygiene. On behalf of AMREF Health Africa, I'd like to say that AMREF is committed to working and serving communities all day, and is always ready and dedicated to serving communities all day during pandemics and in the absence of pandemics. So we like to pledge as AMREF Health Africa that we pledge that we'd like to continue working with the Ministry of Health and its partners in strengthening the capacity of health workers at facility and communities as well, through training and many other issues that come up. So we'd like to actually make sure that we continue with this kind of relationship with the Ministry of Health. And we also like to say that we plan to continue engaging with communities as well through risk communication and demand creation, health partnerships, health system strengthening, and all other activities that are very important in offering solutions to our health system. I'd like to thank the DG for being here and for working closely with AMREF Health Africa as well in all the activities that we've done previously and the ones that we continue planning for in future. I thank you all. Thank you very much.
Once again, thank you so much, Ken and AMREF, for supporting this event. We really thank you, Martini, for the organizational level. So let me invite Dr. Shem from WHO. Dr. Shem, karibu sana. I've worked with him for many years. It's good to see you, Dr. Good morning.
Thank you very much, Hilary. Good morning, ladies and gentlemen. DG, on behalf of the World Health Organization, we just want to assure you and the Ministry of Health and the wider public of the support from the World Health Organization as we prepare to respond to this outbreak of Ebola virus disease. From our part as WHO, we've learned a lot of lessons from previous outbreaks in different parts of the world, particularly in the African continent. And these are some of the lessons that we want to share and as we partner together to make sure that we are prepared should anything come across our borders. Some of the things that we are looking at is having a strategic response plans in place, also being able to support the units at the lowest level as they put together their preparedness plans so that they are able to coordinate and anticipate anything in real time. We also support evidence-based approaches and also listening and understanding concerns from the community. These are some of the things that we have learned in the past, that we have to partner with the community, listen to their concerns, understand how they perceive the threats so as to improve on our risk communication strategies. Also integrating innovations so that we are able to respond in time. So from the WHO, we are supporting the Ministry of Health in collaborating on preparedness activities, also providing expertise from both the country office and the WHO regional emergency hub, as well as also mobilizing funds in preparedness should the need arise for us to be able to respond, and offering any technical support that may be required. So we would like to also emphasize that we need to raise awareness in the communities so that should any Any case, any suspected case arise, then they are able to be detected early and treated appropriately. So without much ado, I want to thank you all, and just to say that we are together in this. Thank you very much.
Thank you so much, Dr. Shem and WHO for supporting us. So, sir, you will allow me, before I invite Brigadier Dr. Kuria to come, allow me now to invite Dr. Amy, the acting director from CDC. Then finally, I'll invite Brigadier Dr. Kuria. Dr. Amy, karibu.
Good morning, ladies and gentlemen. Good morning, DG. All protocols observed. It's great to be here with you this morning at what I think is a very important meeting for all stakeholders and partners that work with the Ministry of Health to come together to talk about how we can strengthen preparedness in Kenya. CDC has worked in Kenya for nearly 40 years and has been a strong partner and supporter to the Ministry of Health over that time. Journalists, we also thank you for being here today. You will play a very important part in getting clear and accurate messages out to the population in Kenya. In short, CDC's partnership with the Ministry of Health is really focused on prevention, detection, and response, simply put. So all of our activities align with those three core missions around health security. So over the last 40 years, but really, since Ebola was detected in other parts of Africa and through COVID, we've been working with the ministry and alongside them on prevention activities. So strengthening support at ports of entry with port health services, also around infection prevention and control. So conducting facility readiness surveys and providing significant training to healthcare workers on infection prevention within facilities and proper use of PPE. When we think about detection, it's really about surveillance and laboratory services. CDC supports and implements through the ministry several enhanced surveillance systems, one based in facilities, but event-based surveillance, which is based both in facilities, but most importantly, communities. And if we learn from what's happening in Uganda, it's really important for us to strengthen community surveillance right now. In terms of laboratories, CDC supports several KEMRI laboratories throughout the country, and through these laboratories we work very closely with other KEMRI laboratories, specifically the VHF lab. We also support system strengthening, so specimen transport, turnaround times for testing. These were all things that were really strengthened throughout COVID-19. And we think that COVID-19 gave us a practice run and really strengthened the health system in Kenya to be ready for where we are today. And then we move into response. CDC has partnered with the National Public Health Emergency Operations Center since 2014, and throughout COVID-19 worked with the ministry to install 18 county-level EOCs throughout the country that support about 50% of the Kenyan population. These EOCs have already been activated under Hillary Limo to be vigilant in their posture, specifically those at borders and along transportation networks in Kenya. And finally, workforce. We're talking a lot about healthcare workers, obviously, strengthening their training around infection prevention and control and PPE. We also support the Kenya Field Epidemiology Laboratory Training Program. These are really forward deployed assets that we saw throughout COVID-19, and no doubt in our preparedness posture for Ebola will be key in terms of being able to send them out, deploy them throughout Kenya to support these core functions to prevent, detect, and respond. So we are really pleased to be here today. Thank you for the invitation, and we're thankful for our 40-year partnership. Thanks.
Thank you so much, Dr. Amy, and also Irene from CDC. As I invite Brigadier to come, once again, it's good to mention that courtesy of Switch TV, we are able now to do the live streaming. Our colleagues at the county level, the POEs, and other stakeholders actually with us. So with this, allow me now to invite Brigadier Dr. Kuria to come and be able to give his remarks, and finally invite the DG to present. Dr. Kuria. Join me to invite him kindly. Thank you so much.
Well, thank you, Limo. Thank you, my colleagues from CDC, WHO, and Director General, University of Nairobi. Now my colleagues who are here from the Director of Public Health. It is interesting, I've just jetted in from United Nations General Assembly, where we had a very nice talk on what happened as we responded to COVID-19. Huge discussions on the iniquities that were experienced, especially in the supply and distribution of vaccines, PPEs, and other tools that were used in the management of COVID-19. And we must confess that as a ministry, it's been back to back, one outbreak after the other. We're just reeling from monkeypox. We're actually getting more ready to do with monkeypox. And now here we are again, preparing to fight Ebola. What we are here to affirm to the nation is that indeed the country, with all the lessons learned from COVID-19, we are equal to the task, and we shall handle this. And to assure Kenyans that as a directorate, as a ministry, the ministry is up to task and is making every effort to ensure that the country is protected. I'm sure they have been very, very concerned over surveillance efforts, and to reassure Kenyans again that surveillance efforts are in top gear, and everyone, if nothing is being left to chance. We were preparing also to make sure that everyone who is going to respond to the pandemic has the right tools at the right time, so that we also don't lose healthcare workers. Most importantly though, and thank you DG for convening this event today, that you disseminate information that the country is so much in dire need of. And I'll probably like to quote Hosea 4:6, where people are perishing because of lack of knowledge. And I'm hoping therefore DG, through our presentation, you'll be able to shed some more light as to what Ebola is. Some just have fears for nothing. Reassure Kenyans that indeed it is manageable and we can do it. So I'm sure DG, you have a nice presentation on this one. I don't want to steal your moment. Allow me to invite you to make your remarks and a nice presentation that you have prepared for us. And reassure Kenyans that indeed we are ready to handle this, and we will do it. Whatever gaps that may be identified, we are marking all of them. We don't say we are 100% perfect. We learn through experiences, and we will be ticking our boxes where we think we have not done enough, and we're improving on our levels of preparedness as we move along. So without further ado, Director, DG, karibu sana, and the floor is yours. Thank you very much.
Thanks, Dr. Kuria. WHO representative, my colleague and friend, Dr. Shem Kiton, Dr. Ami, Acting Director for CDC, Dr. Mary Beth from the University of Nairobi, our colleagues from AMREF, Red Cross, Josephine from UNICEF, technical staff from the Ministry of Health, who continue to do a marvelous job despite a myriad of challenges thrown at us every day. Right? Oh, I thought this was on. So do I start again? Oh. WHO representative Dr. Shem Kipton, CDC Acting Director Dr. Ami, Dr. Mary Beth from the University of Nairobi, Ken from Communications of AMREF, and thank you for hosting us here. Josephine Odanga from UNICEF, Red Cross representative, the technical staff from the Ministry of Health. Maybe you can stand up. The guys who do the cooking in the background, technical staff from MOH. A big thank you to all of you for a wonderful job done. Please have your seats.
Members of the fourth estate, I don't know why you are not the first estate. Ladies and gentlemen, good morning. As Dr. Kuri has stated, we are in a new world order where each and every day a new challenge, especially of a public health nature, at us. As a country, we have always prepared for Ebola. I remember in 2019, before COVID-19 came, we actually developed a contingency plan for Ebola. We had very many false alerts. We responded, but it came to pass because that outbreak then was in the DRC. This time the outbreak is closer to us in Uganda, in central Uganda, in a district called Mubende, less than 150 kilometers from Kampala. And we all know the kind of human traffic between Kenya and Uganda. And this therefore puts us at a great risk of importation of Ebola into the country. But where we are situated, we are confident that with the lessons learned from COVID-19, we are in a better position to be able to mount a response compared to before, because we can leverage on the structures that we developed during the COVID-19 pandemic to be able to mount a response. That notwithstanding, if the nature of the enemy that we are going to deal with is a little bit different from COVID because of human-to-human transmission of Ebola. And therefore, the community is going to play a critical role in case we have an identified case in the country in stemming the outbreak. And because as a Ministry of Health we cannot be able to reach all members of our society, we have called you, the media people, to be our partners in this so that we can be able to convey correct, factual, scientific information. And the reason we did this was to ensure that from day one, we all read from the same script and convey the right information, because even if you are talking about surveillance, as a ministry, we don't have capacity to offer surveillance to all the entire border between Kenya and Uganda. And therefore, we are appealing to you to be able to reach out to the communities, to convey the right information so that each one of us becomes a community-based surveillance officer. If we do that, we will quickly bring this outbreak to an end. And I believe our colleagues in Uganda are trying to do that. However, the challenge they have had is, of course, the lag time between the identified case and when the outbreak probably began, which we think is probably sometimes in August. I will take you through a few slides about 15-16. After that, we'll have a panel discussion where we'll be able to respond to all your questions. Please feel free to ask any question, irrespective of how stupid you think it is. I think it is up to these technical people from WHO, from the ministry, from CDC, to be able, from AMREF, from UNICEF, to be able to offer explanations so that as a country we start this journey together. So slide 1. So this is the outline of my presentation, the situation update on the outbreak in Uganda, our risk assessment or perception, our preparedness measures, the actions that we have taken thus far, and what is important is the country contingency plan, because we are member states of WHO, and therefore in terms of dealing with an epidemic or an outbreak, you need to have a plan. And that is why up to this point we have not communicated to you formally, because we are still developing the plan. If you don't have a plan and we just come to you, then in terms of how we are going to mount our interventions, they may not be coordinated, and therefore they may not yield the desired results. So Uganda declared the outbreak following a confirmation on 19th. It was first reported in Madudu sub-county in Mubende district in central Uganda, less than 150 kilometers away from Kampala. As at yesterday, 2 other districts had reported
at least a case each. And so far, the 36 cases reported, there are 23 deaths, giving us a case fatality rate of 64%. The standard case fatality rate for Ebola is about 50%, but it varies from outbreak to outbreak from 25% to 90%. So you can be able to see how high the case fatality rate is. In terms of our risk perception, owing to our close proximity to the Republic of Uganda and the huge human traffic between the two countries, at both the formal border points like Busia and Malaba, but of course the numerous porous borders. Then the international flights coming to JKIA, Eldoret, Kisumu, and more international airport, Mombasa. We also have a significant population of Ugandans and even others from DRC, in Nairobi, Kajiado, in the refugee camps. And therefore, owing to these risks, we are implementing effective measures to ensure that we stop, one, the importation of the outbreak into Kenya, and two, if it does happen, then we put into place control measures. We have stepped up our surveillance system at the formal border points, and we are now in the alert phase, and that is why we are still having this discussion in hotels. But in case we report a case, then we move to action. Next. That is a map, a hotspot map of Kenya showing us potentially where we could be able to get the first case. And nearly half of the 47 counties, 20 out of 47, are at risk. Of course, the entire stretch bordering the Republic of Uganda, all the way from Turkana in the northwest to Migori in the southwest. Then the line stretches all the way from Busia along the A104 highway up to Mombasa. So all those countries marked in red are potential hotspots, and probably that is where we would be able to get the first case. In terms of preparedness, critical for outbreak control is coordination, so that people work in a structured way, and therefore our own individual efforts leads to a multiplier effect. One of the things that we have done is activation of the EOCs, the Emergency Operations Center, and we have developed a national contingency plan, which tells us the activities that are required to do during the outbreak. Critical, of course, is surveillance, and all ports of entry have been put on high surveillance mode, and screening of passengers has already begun. But this can only happen in the formal border crossing points, and that is why, as custodians of public information, we appeal to you, the media, to ensure that we dialogue with fellow Kenyans so that we are each other's keeper in terms of ensuring that even those who cross through informal points which are not monitored by the government, then we can be able to pick events and be able to report to the health authorities. We also issued an alert to the counties last week. We have developed the case designations for Ebola and the necessary fact sheets, which we'll be sharing with the public and the health facilities. And we have finalized the contingency plan. As at yesterday, we had screened close to 19,000 people passing through the formal border points. But I want to emphasize that this is a drop in the ocean because the informal border points are not manned by any person. And therefore, the healthcare worker to be able to man the informal border points is me and you, and all of us Kenyans. Why the contingency plan? Because the plan provides for surveillance, it provides for preparedness, and how we mount a response plan. Previously, the Republic of Uganda has reported Ebola outbreaks, DRC, but this time we believe the risk is much higher because of the proximity of the epicenter of the outbreak, and of course because of the human traffic between Kenya and Uganda. We are also obliged under the International Health Regulations 2005, which is an international instrument legally binding that requires all state parties who are member states of WHO to strengthen surveillance and response capacities for public health events like what we are dealing with. I want to emphasize at this point that so far the country has not reported a case of Ebola. It is important, but that does not mean we lower our ante. We need to ensure that our antenna is at maximum so that when that case eventually comes, we can be able to pick it early and ensure protection of the public, but also critically the healthcare workers because of their high level of exposure. And our contingency plan is intended to serve as a guide for the prevention, preparedness, detection, and our response plan. It highlights the activities that we need to undertake, the roles assigned, the responsibilities, the procedures, and in some cases, accountability in who does what at what particular time. And that is why we are gathered here as a multi-agency team. Basically the same approach that we used during COVID-19 of whole government, whole society approach. The plan, therefore, is to ensure surveillance, identify, detect cases early and promptly, enhance our preparedness, and ensure our capacity to be able to handle a case. Yesterday I was asking the technical team, and Dr. Mary Beth Maritim is here, that, for example, if somebody lands from Kampala showing symptoms of Ebola, are we ready at KNH? And I was assured that in Nairobi we are ready to receive the first patient, which is good because of the systems that we have put in place. And basically what this tells us is the need for health system strengthening, which is our approach towards universal health coverage with a strong emphasis on health prevention, health promotion, and strong community participation. Next. This is a multidisciplinary task force. At the apex is the technical task force that will be chaired by the DG, but above that is another committee that is responsible, the Cabinet Secretary for Health. I believe a situation may arise where we may be able to have what we had like in COVID-19, the National Emergency Response Committee. And you need to identify the risk factors for Ebola introduction to the country. I show you the hotspot map where we mapped out potential areas of risk. We have set up mechanisms to be able to respond to any potential risk factors for EVD introduction. We have identified the high-risk areas. We intend to create more capacity at the points of entry for detection and how to screen for suspected EVD, how to manage contaminated materials is a whole gamut of interventions that will be able to safeguard public health. Next. This is how the organogram of the contingency plan. The executive oversight will be provided by the Cabinet Secretary and Principal Secretary. And if need be, that will be extended to the other MDAs, ministries, departments, and agencies. But below that is the task force that is chaired by the DG and Secretariat to be able to organize the logistics. Then we intend to be able to scale this down to the counties the way we did for COVID-19. So we expect in the high-risk counties that we have a mirror representation of the national task force at the county level. They will also be able to have other subcommittees, including surveillance, case management, risk communication, laboratory, WASH, logistics, and even resource mobilization. Next. The implementation of this plan, one of the critical elements of this plan, of course, is capacity building and creating public awareness. And that is where we have decided to use the cat's paw, use the media as our partners to be able to convey this information, because you have a larger outreach than us as technical people at the ministry. And we need a consistent, coherent concise and scientific messaging to be able to ensure that the message that is received in Turkana is the same as the message received in Migori and same as the message received in Mombasa, so that we are consistent. You know the damage the infodemic did during the pandemic, so it is very important for us from the word go to get the correct messaging so that the public have confidence in the interventions we are implementing. Next. So these are some of the interventions during a confirmed outbreak phase. That is now the action phase, coordination and resource mobilization. And other speakers who are here before me, like UNICEF, is very, very strong in terms of logistics management. When we require specialized PPEs for Ebola, not the ordinary ones, then we can be able to leverage on UNICEF through their supply division in Denmark to be able to ensure that the supplies reach here in a record time. Surveillance, because for us to be able to ensure public health safety, all of us have become surveillance officers. Because events happen at home, at communities, please, let's be very, very quick and alert to be able to inform the relevant authorities, the health authorities, the national government administration officers, the Ngao, the Nyumba Kumi, in case of any unique event. Remember, ladies and gentlemen, even the outbreak in Uganda, how it started, and why we say this probably started sometimes in August. There was a constellation of deaths around the Mubende sub-country related to 2 facilities where people had been admitted, including that of a healthcare worker. Had that been picked earlier, the diagnosis would have been made a little bit earlier. But we believe Uganda, with their systems in place and their previous experience in handling previous outbreaks, we are confident that they'll be able to bring this to a halt. We are also glad that as at now, we have not had any reported cases from Kampala, because if that was to happen because of the population of Kampala and the number of Kenyans who travel to Kampala daily, then the risk again will be quite significant. Next. The successful control of Ebola virus disease outbreak. Community engagement is key to successfully controlling outbreaks. Myself as a DG, my technical officers, we cannot be able to reach all the 50 million plus Kenyans. We plead with you, the media, to amplify this message, to know that this is within our hands to be able to bring a potential outbreak or a real outbreak to a halt by simply practicing basic measures that may not require any significant investments. And it relies on a package of interventions, including case management. That is why you have the University of Nairobi here. They also support us in terms of modeling, projecting the number of potential cases that we are going to deal with, and therefore planning how the health system is going to respond. Infection prevention control measures or practices are key, and this needs to be undertaken by all of us. Again, now we are back to basic hand washing with soap and water and alcohol-based sanitizers. Surveillance and contact tracing. This is the most difficult part in terms of outbreak control. It requires a lot of investment to be able to do proper surveillance and contact tracing, because one person in a day can be able to have, on average, how many contacts? In terms of tens or sometimes hundreds. So if you are to draw that contact tree, the roots will spread further and further. And for each contact, probably you require 1 or 2 technical officers to be able to follow. That is why we are saying that all of us become surveillance officers at community level, so that we can be able to utilize the constrained health workforce that we have in the country. Good laboratory service for diagnosis is critical. For now, we have designated KEMRI as our laboratory of choice for diagnosis. But as the situation unfolds, we are able to bring more on board, including CDC, the University of Nairobi, ILRI under the One Health approach, and others which meet the requisite parameter set. However, because of biosecurity and biosafety requirements, because of this highly infectious pathogen, if it lands in the wrong hands, you know potentially what they can be able to do with it. That is why we are narrowing the number of laboratories for case identification in the early phase. Even our colleagues in Uganda are using UVRI, Uganda Virus Institute in Entebbe, which is a WHO designated viral hemorrhagic lab for their diagnosis. Social mobilization, critical again, and therefore it is whole society, whole government. We have agreed from our meeting today that all of us have become events-based surveillance officers who should be able to pick our phones, be able to send messages, be able to make calls, and therefore alert the healthcare system to be able to mount a quick response. Finally, safe and dignified burials. We saw what happened in 2014, 2016. And because of our cultural practices, I know what happens in Western Kenya. The Lake Belt region, their cultural practice, Busia, Bungoma, Trans Nzoia, is key for us to be able to send a correct messaging so that in case we have a death due to Ebola, then during the burial, we institute safe but dignified burial practices, being cognizant of the cultural requirements, but also putting health safety at the very apex. The public have advised to citizens, and we had sent this earlier in our early alert through the press release that was given last week, and also the alert to the counties. Usually sudden onset of high fever, vomiting, you may have cough, sore throat, chest pain, diarrhea, measles-like rash, and bleeding from body openings. You can have bleeding from the gums, bleeding from the nose. All these are non-specific symptoms. And actually the first index case in Uganda was initially being treated for malaria and typhoid in one facility, did not respond, transferred to another facility. Then they noticed episodes of bleeding, then was referred to the district referral hospital, where a diagnosis of viral hemorrhagic fever was made and confirmed at UVRI. It is important, we have activated 719, and these numbers, please the media, we can be able to pick those numbers, those two numbers, so that we can be able to share them with the public. We are also appealing that at this particular moment, you avoid unnecessary travel to areas reporting an outbreak as a precaution. And all travelers who have come from Uganda, especially Mubende, and have developed any of the above symptoms should immediately report to the nearest health facilities for assessment. Members of the public residing in the border areas all the way from Turkana to Migori in the southwest should report any visitors coming in through the informal routes to the national government administrative officers, the chiefs, assistant chiefs, county commissioners, assistant county commissioners, ward administrators, the Nyumba Kumi initiative, and the village elders. We used this during COVID-19, and at one point it worked very, very well, especially in the border towns like Migori, for example. If you came in from Migori and you came in from Tanzania, because during COVID-19 we had put measures while Tanzania, no specific interventions had been undertaken. It was usually the public who would be able to alert the health officers that in this particular home there's a guy who came from across the border and he looks sick. Members of the public are further advised to adhere to infection prevention control measures which I had earlier talked to. Hand washing. No, the social distance, I think that one is misplaced, please. and even wearing of mask, not mandatory at this particular hour, except caregivers. If you are taking care of an Ebola patient, and I believe you are not going to take care of Ebola patients at home, so that will apply to healthcare workers in the designated healthcare facilities. But the second bullet is important. Avoid touching or cleaning dead bodies, especially where people have died of illnesses of unknown cause. And it is important for us to be able to pass this information to the healthcare authorities so that they can be able to assist in a dignified burial by offering the necessary protective packaging before burial. The last one will apply to before the onset of the outbreak, because usually the reservoirs for Ebola are fruit bats and those other primates. And in some of the African countries, people actually love bushmeat. And therefore, that is how the pathogen jumps from the animal reservoir to the human being. There are 6 species or types of Ebola, 4 of them which cause Ebola virus disease. That is the one that is in Uganda now. It's called the Sudan species. Then there's the Zaire species. Then we have Bundibugyo. We have the Thai forest, Reston, and finally Bombali. Usually they are named after where they were identified. I know you are going to ask about the vaccines. I will preserve that for the panel discussion because there are more learned people here than me who will be able to expound on that. I think that is my last slide. Thank you. We will have a panel discussion, and we appeal to you to be able to ask all sorts of questions so that we get the correct responses from the word go, such that as a country we all read from the same script and also speak from the same script. Thank you.
Thank you so much, DG. So with humility, I'll be inviting the following, with your permission, to the podium. I'll invite you, the DG. I'll also invite Brigadier Dr. Kuria, Dr. Preparedness Maritim, Dr. Amy, Dr. Kiru, and Shem Kipton, kindly, if you don't mind, for now. Then, following your advice, I think we can be able to extend later on to Dr. Langat, Josephine from UNICEF, Caleb Chemirmir, Ken from AMREF, Susan, and then Dr. Irungu. So with your permission, sir, please kindly. So please, this is the right time. We have the panelists. Maybe give you a chance. Please continue working. We'd like to give you a chance. Let us know your name, the media house, and maybe whom you are addressing the question to or a concern to. Yes, so I think we are set. We have the mics. Can I see the first person kindly? The first person, yes. Mercy, you will assist me with the mic. Mercy, if you don't mind, one of the mics.
Zainab Mohammed from TV47. This is to the DG. My name is Zainab Mohammed from TV47. This is to DG Amoth. Is Kenya contemplating stopping flights from Uganda to Kenya? Is the country contemplating stopping flights between Kenya and Uganda?
Oh, my name is Sharon from Capital FM. Today in the morning, people on the Twitter, they're like, why do Kenya not close the border so people don't cross to Busia? So what's your plan? Are you going to close the border? Is there any strategy you're going to use to prevent people coming from there? Because now, Busia and Uganda, people can just, they can use foot to cross. It doesn't have to be, they can even use vehicle. It's not about flying. So what's the plan?
My name is Helen Aura from NTV. The third question would be, you had earlier indicated, I believe this was from the beautiful lady who had spoken about the porous borders. Earlier on, Malaba residents who reside along the Busia-Malaba border had expressed concerns of especially the truck drivers who ride in from Uganda to Kenya and the business people who have to go to Uganda as well to do business then come back to Kenya. You had earlier indicated that you've already deployed health workers there who are already checking people and checking temperatures and ensuring that the health of those who are crossing the border is up to par. But what of the incident that someone does not show any signs and symptoms while they're crossing, but develop signs and symptoms while they've already crossed into the country? What happens? Are we only now relying on checking at the border points, or can we take more effective measure? Yeah.
My name is Ben from K24 TV, and I'd just like to add more to what my colleague Helen has asked. What is the incubation period of the Ebola virus? Once you contract it, at what point will you begin showing the signs and symptoms? And does everybody show the similar signs and symptoms with the same incubation period? Thank you.
Okay, I'll make my comments, then I'll invite my other colleagues to be able to jump in. The first question was about stopping flights from TV47. No, under the IKR 2005, we don't intend to stop flights, because even if you stop flights, remember that we have talked about the porous borders. It is safer to have somebody come through a designated flight where you can be able to take contacts, you can be able to take the details, and it makes your follow-up easy, rather than close the designated points of entry, including flights, then people come through clandestine areas where you have no control. I think that also answers the question from our colleague from Capital FM. We don't intend to close the borders. Indeed, if you remember in my presentation, what we have tried to do is to ensure that we have a heightened surveillance system, and that is why we are appealing to everybody to become a surveillance officer, because these events are going to happen at home in communities, and therefore with that in place, we can be able to pick them at the earliest opportunity and put in place the correct response measures. That also addresses the question raised by Helen Aura. Yes, we don't have the capacity to be able to police the entire border, but that is why we want to keep the borders open so that those who come through the borders, then we are able to keep track of them. Those who don't come through the formal border points, we appeal to you as our partners to be able to convey this message so that everybody is on high alert, that in case a situation arises, we can be able to respond. There was the question of the incubation period. Unfortunately, this one has a long incubation, short to fairly long, from 2 to 21 days, from 2 days to 3 weeks. So true, as Helen said, I could cross over from Kampala, exhibit no signs and symptoms, and clearly passed as safe. But later on, I developed the signs and symptoms which I shared with you there. So even if you have to do the surveillance, it is still key that at the community level, at the household level, all of us are clearly aware of the potential signs and symptoms of this disease, and when it does arise, then we can be able to report so that the healthcare workers can be able to take the appropriate actions. I would pass over to Dr. Kuria to be able to add on to it, then Dr. Marybeth, Shem, and Amni, and then Dr. Kiru will sum it up, just to echo what I've said earlier.
Well, thank you, DG. And I think responding to Ben K24 especially, and the short to long incubation period of 2 to 21 days. And of course, what we see, we have heightened surveillance. It's not surveillance just at the borders, it's surveillance even at community. Wherever we are sitting, we are also doing surveillance. And I think the DG highlighted the need for all of us in the community to be involved here, the media and the communities. So that if you see someone who traveled from Uganda recently, and you know him and your neighbor knows him, it's a high time that we protect the rest of the country as Kenyans. So if you know someone who traveled from Uganda, start eliciting signs and symptoms that you have seen them, their cough, a fever, abdominal pain or what's unexplained, vomiting, alert someone else in the community so that then the surveillance officers in the county or sub-county can be alerted, and then you can follow up that case. The case can still develop severe symptoms, although they are light without symptoms. So much as we are emphasizing the need for surveillance at the border points, it's not just the thermogans and the temperature screening at the borders that is going to help us. It is those who have come in, that history of travel from Uganda, history of travel from even the DRC. Again, let us not limit ourselves to just the Sudan variant. Let us also be on surveillance even for the Zaire and the DRC variant. So that history of travel and then developing symptoms, let all of us out here be on the lookout for any symptoms developing and report such cases. Some may not have come in through the border, but us as communities should be able to respond and protect the rest of the country. So it's surveillance by all, not just by Port Health, not just by the ministry. All of us here have a role to play in this surveillance system. Thank you.
So just to add to the sentiments that have already been said, Ebola virus disease is very contagious. It's transmitted by direct human contact, and the virus can actually penetrate intact skin. So coming into close contact with people who are infected within the household, maybe taking care of them within the hospital, then provides that amplification of the infection, because any person who's in contact can then potentially get infected. In terms of the symptoms, as DG mentioned in his presentation, fever seems to be the commonest manifestations, but the other symptoms like cough, diarrhea, sore throat, vomiting, they're really non-specific symptoms. So it's really up to all of us to have that heightened awareness that if you have someone who presents with some of these symptoms, then the next question to ask is to find out where they have come from and whether they have traveled recently, and more importantly also to take the infection prevention and control measures to protect either within the household, the other members. And that's why even in DG's presentation, he alluded to the safe burial, because in many of our communities, when we lose our loved ones, there are some procedures that people do that puts people at increased contact, because the virus will still be shared even when that person has passed away. So it's really, really important to understand, and DG emphasized that point when he was talking about the slide of social distancing. This one is close contact. So even if someone is already sick and maybe they are contaminated, maybe their hands with the vomiting, and you touch their hands, that virus can actually penetrate intact skin. So you don't need to to have a cut in your hands and something like that, the virus is able to penetrate the intact skin. The incubation period being long makes us very wary because some people can develop their signs fairly early, the symptoms and signs fairly early. But to give someone a clean bill of health after, you talked about the contact tracing, you have to list all the potential contacts and follow them up for a period of 21 days to say someone has escaped the infection, because it's very contagious. The incubation period is very long, and therefore you have to observe the people for very long. So even for the people who may be traveling back in, it means that even their surveillance has to last that period of time before you can say someone is not potentially infected. So again, remember, some of these signs are non-specific, so it's really up to all of us to be vigilant, be it at the border points, be it all the areas along the highway, so that we can all look out for people who will present with the symptoms. And at the bottom of his presentation, he had the bleeding from different points from the body, like from the nose or the mouth or even bloody diarrhea. Those manifestations come later. So it's really to have that heightened awareness that someone can present with fever and something else vague. And for the outbreak, particularly in Uganda, there were clustering of unexplained deaths within a certain community. So that's another thing that you need to look out for, assuming that the case had been introduced within a setting, to try and explain, like if people are dying and they were in contact with each other closely, it could mean that they potentially were infected. So looking back, we actually missed, the Ugandan people missed that initial presentation because they were not at heightened awareness. But when they saw all these people dying in close contact, then they were able to actually suspect that something had circulated within that population. Thank you.
Thank you. Just to build on what was just said, what we've learned from previous Ebola outbreaks is that we generally see dry symptoms earlier on, so that's the fever, cough, and then the wet symptoms come later. So that could be diarrhea or bleeding. So that's a sort of easy way to think about that. And to the points, we know we're doing everything that we can at the borders, but it's really enhancing surveillance and heightening surveillance throughout the country. So this is what the U.S. Centers for Disease Control and Prevention is doing along with the ministry. Facility-based surveillance is being strengthened and enhanced, but it's really event-based surveillance. If we've learned anything from Uganda, over half of the deaths have occurred in the community and never went to a health facility. So we've got to be able to detect unusual clusters of events in the community, and that's exactly what event-based surveillance does and exactly what the DG has been encouraging all of us and all of the Kenyan people to become. Thanks.
Thank you very much. Maybe I can add a few things. I wouldn't like to repeat what has already been said. One of the things that we would request the media to do, once we have refined our case definition, definitely the DG will be communicating. It's very, very important for the media to sensitize people on early symptom detection. Because if you can be able to know that you are not feeling usual, then when the testing is done very early and diagnostics confirmed very early, the case management becomes easy. So it's very, very important that each one of us in the next 1 week be able to monitor themselves. So we need a lot of self-awareness. And also, if you feel that something is changing in you, then it's very important for self-reporting and to have good treatment-seeking behavior. The reason being, the earlier you present yourself, the better. But suppose a case arises today and there are all the symptoms that seem to point to Ebola. It's very, very important for people, especially both in the counties, private and public labs, to know that testing of this sample is as dangerous as handling it. So it is very, very important for you to let us know, because we have put a network of sample testing. Ebola cannot be tested by everyone because it requires advanced laboratories which are called level 3, and this laboratory must have negative pressure. So do not get a patient and you start testing the sample, because actually you could expose yourself. The most important thing I believe very soon there will be a call line where you can call, let us know, and we'll make arrangement for safe sample extraction, sample transportation, and self-testing. Thank you.
My name is Tony Kadenya from Wero TV. Niko na swali moja tu. You talked about emergency centers, and maybe I would like to know how many of them do we have so far in the country, and how many public hospitals have the emergency centers.
Thank you. Next, may I see by show of hand, kindly? We are actually doing very well. Any other person, any other colleague from the media house? So Emily, do we have questions, Emily and also Stanley? Are you able to project? Yes, so these are the questions from our colleagues from the county. So, DG and the panelists, these are the questions, and I know they are following and waiting for the answers. So before we respond to that, do we still have any person from the media house who would like to ask a question? None. So let me hand back to you, DG and the panelists.
Dr. Kuria will respond to the question on the emergency operation centers. I think question 1 is already answered. Question 2, Dr. Mary Beth Maritim will be able to answer. Who would want to go for 3? Looks non-specific. Can you tell the one who has asked question 3 to be able to rephrase it a bit? It is not making sense to some of us. But Dr. Kuria, you can have the floor.
Thank you. The question was on how many emergency centers we have in the country. And as I said when I was in my few remarks, lessons learned in COVID-19, we held an emergency operation center where we coordinates with the National Emergency Operation Center. And we have such a center in virtually every county. I know there are reports of 18 EOCs. Those are the EOCs that are supported by CDC, that have specific equipment and data management tools. But basically every county has an emergency operation center that coordinates with the National Emergency Operation Center for purposes of coordination. There was a question that was last there, how we are going to do surveillance in some fish waters and swimming points, and I think the most important aspect of this disease is understanding that the point of transmission is person-to-person contact. So I would think that it is a high time that some of these, even only those water collection points, and you have suspect cases in your community, that we get on the high alert and avoid contact as much as possible. Again, it highlights the point of when we talk about barriers and we have heard about community deaths, and avoiding contact with these bodies that could potentially have died of Ebola. And even for our fellow healthcare workers, it is a contact with that infected person that is going to risk their life also. So much as we talk about masking, social distance, the most important thing to point out here is the person-to-person contact. So the use of gloves will be very, very important for our healthcare workers. And as a ministry, we are trying to scale up the distribution of these highly effective gloves to every healthcare worker. Masking will also be important, but again, we don't want to skim down the issue of wearing of masks because we are still managing COVID. And COVID, there's nothing that stops COVID coexisting with Ebola either. So we continue using the face masks by the healthcare workers especially, and the use of gloves. And for the community out there, do not handle anybody, any meat that is suspect with our bare hands, because indeed transmission can occur. So at water points, basically avoiding contact. Do you avoid swimming? If I were to be asked in an area where there are community reported death, I would avoid that swimming altogether. Thank you.
I just wanted to add on to the second question, and this was around the masks. So when you're talking about Ebola and Ebola virus disease, it's in the context of infection prevention. It's the full PPE, which will include the coverall, the gumboots, the goggles, the N95 mask, and hair protection, and then an apron in front. So it's actually the full PPE, because we talked about the main mode of transmission is contact, and it penetrates intact skin. It can penetrate through the eyes. So that is actually full PPE. And I know during COVID, as the pandemic, we went through the pandemic and we got more evidence, we actually recommended less and less PPE, even in the COVID-19 treatment units. But for Ebola, it's actually full PPE, like how we managed COVID before, where you have to protect any part of your skin, your hair, so that it's not exposed. And therefore, it's not only looking at masks alone, it's actually the full PPE. So for the healthcare workers and for the people who are listening in from the counties, it's actual full PPE. Thank you.
Okay, yeah, I think one other thing that I wanted to respond to, although it's not one of the questions here, with regard to the vaccine, is that at the moment, the vaccine that we have, we do not have evidence that it's protective against this particular strain. However, there are ongoing development of at least 7 other vaccines which are targeting this particular strain, and WHO is working to expedite the process of evaluation to ensure that should it be required, then it will be available in the shortest time possible. So that's with respect to the vaccine that the DG had alluded to in his remarks earlier.
Maybe I can add something on question 3, not exactly, but related to that, because I think question 3 was on infection control measures. Suppose somebody in your house develops these symptoms, and you look at them and you say, these are characteristics Ebola symptoms. What do you do? I think the most important thing is try to protect yourself. I know sometimes when you're in such a situation, your adrenaline kicks in and sometimes you become, you just want to protect them. But it's very, very important to know that you also have to protect your life, especially if the symptoms have already kicked in. So I believe there will be more guidance on this, but the most important thing is if you have a mask, use it. If you have decontamination like a jig or ethanol, spray around, because you can also get this pathogen from the services. Then it's also very important to use gloves if you do have them. I know this looks very ideal, but I think it's very, very important when you have a case that look characteristic of Ebola to know exactly how to react. The other one is it's very important to note who has come in contact with this person, especially in the last 21 days, and their travel and movement patterns if they are available, because containing that case will mean stopping other 10 or 20 cases. Thank you.
Thank you so much, DG and the panelists. We have 2 more before we come to a conclusion, and those are the questions from the counties. So as we go through the counties, I know in the room we have Dr. Omar. We'll be talking about psychosocial support. We'll just give him a minute or 2 after, just to give a remark. So let me hand back over to you, DG, and the panelists for the 2 questions.
I think for question 4, the phase that we are in Uganda is not a question. The pathogen has already jumped from the primate or the other reservoirs into human beings. So the main mode of transmission is now person-to-person contact, either through caring for an ill person or getting into contact with a dead body, secretions from a dead body, or from a contaminated surface. And unfortunately, I don't think we even have the capacity to stop monkeys jumping from one border to the other. So the main thing now is to be able to focus on us as human beings to be able to forestall human-to-human transmission. And basically what we are saying is that if you are able to put all these measures in place, then we can be able to stop the transmission and break any potential outbreak to an end by simply taking care of these basic infection prevention control measures, which may not require a lot of resources. And that is why we still continue to appeal for us to be able to sensitize all of us, the communities, the families, so that we have the correct information and we take appropriate action. Question 5, yes, I think that is the gist of our meeting, is basically to be able to bring the communities up to speed of how to identify a potential case, what measures that we need to take, and therefore risk communication is actually a pillar of one of the thematic groups of the National Task Force. So we are going to see more messaging in terms of radio messages, TV clips, newspaper adverts, and all modes of communication. We agreed that we are going to have this initial meeting. Then after this, the technical experts will move on into the TV stations, the radio stations, to convey one uniform, coherent, concise, precise, scientific information. Any member can be able to give any additional information, please.
I wanted to add to what the DG has mentioned, and this is with regard to question number 5. It's really about communicating the message to the communities to be aware of the presentation and what to look for. But in addition to that, I think we really need to strengthen ways to deal with stigma, because we know in the past in places where Ebola has broken out, patients who are survivors or families actually become stigmatized. So we really need to be aware, and I think as the media, we really need to be cautious, because most often before an outbreak, is waiting for that first case. And sometimes that first case becomes stigmatized and the family becomes stigmatized, where people perceive negative feelings about that person or their family. And we've seen people who've actually, like Ebola survivors in other outbreaks, who've had to deal with that stigma, even having survived, which many of them actually, like the burden of the stigma affects them for their entire life. And some people maybe even wish that they may not have survived, because we know that the case fatality rate is very high. So we really have to have a balanced sense of maybe reporting or commenting, so that we are not looking for the story, but thinking of the person behind the story, rather than sensationalizing that individual person, because then people always, because Ebola is not always thought about in positive terms. I think any new disease is not always thought about in positive terms. So we really need to be balanced and cautious, so that we are not perpetuating stigma while we are trying to report even potential cases or outbreaks. And we also see this because when people perceive a stigma, particularly for a new infection, then you'll hear people running away or attempting to run away from treatment units. So we need to really have a balanced judgment where we care about the person and not put the story before the person, and really try to protect these people, because it's not their own fault that they chose to be infected. So we really have to be cautious and think about the impact of what we will try to do, even as we anticipate this outbreak. Thank you.
Just to add to that, I'd really like to commend the Ministry of Health for their quick action. The day after the case was detected in Uganda, the Ministry of Health began to bring subject matter experts together here in Kenya. And it's important that not only every Kenyan receives this information, but every person working in a health facility. Because again, learning lessons from previous outbreaks and what's going on in Uganda, cases don't come to the largest referral hospital. Because of those those early dry symptoms of fever and cough, people often think that they have flu, and so they just go to the lowest level community facility. And so the provisions that are in place to provide PPE and training to all is really critical, I think, as we strengthen our preparedness in Kenya. Thanks.
To add on to that is, of course, the economic devastation that potentially this virus can bring. We remember that 2014-2016 West African outbreak, the three main countries of Guinea, Liberia, Sierra Leone, the total economic loss is estimated at more than $4.3 billion. So the correct messaging and measures we put in place to bring a potential outbreak to a close, the earlier our economy is protected. Remember, we are just beginning to recover from the effects of COVID-19. So to emphasize what Dr. Maritim was saying is that correct messaging, even as we communicate, so that we don't drive an infection underground because of stigma, but to inspire our people to be able to come up to the health facilities so that they can be able to receive care.
Thank you, DG and the panelists. So there are three requests, final ones. One is that we have a colleague from the media house, one person, yes, ask you a question. The second one, we have Caleb from Kenya Red Cross. And finally, from the county.
Yes, I do. Yes. My name is Jael Chemtai. I'm from Kenya Broadcasting Corporation, and I have a question to the DG. As far as mental health is concerned, what is the government doing about it? Because recently, the cases has really risen up.
Yes.
Sorry? I'm talking about mental health.
Yes, earlier on I mentioned that we have Dr. Omar, and she's with us. I'll give her the mic to respond to your question.
Okay, thank you.
Please kindly repeat your question again.
Yes, I'm talking about mental health. What is the government doing concerning it? Because the cases has really risen up.
Okay, so we are doing a lot in terms of, for the first time, we have mental health and psychosocial support as part of our emergency preparedness. And we had it during COVID, and we also have it, we are a key pillar now in the Ebola response. The other thing that we are doing is that we have come up with a national suicide prevention strategy. As you know, the suicide cases are going up in the country, especially among young people. So we have a suicide prevention strategy. We launched it last year. So we are working now on implementation of that strategy. The other thing is that we are supporting counties in terms of setting up their own mental health teams. And we have been able to get focal persons from all the 47 counties, which is a big step for us. The other thing that we are doing is also supporting counties coming up with a mental health action plan, because as you are aware, health now is devolved. So a lot of the function now is gone to the counties, especially in service delivery. So 2 counties so far have an action plan. We have the county of Kajiado and Kilifi, and we are supporting other counties. Nyeri right now is working on their mental health action plan. And the other thing that we are doing is that we came up with a mental health investment case. We launched that last year, and it has actually shown that mental health conditions cost the Kenyan economy 0.6% of our GDP, which is around 61 billion Kenya shillings. And that is not really on healthcare cost, but cost in terms of absenteeism from work and low productivity of the population. So, and it has also shown that return of investment in mental health is actually double the return on investment. So right now we are also lobbying for getting more financing for mental health at national and county level. I hope that answers.
Okay, thank you.
Thank you.
In addition to that, of course, we are trying to entrench mental health services at the primary healthcare level, and also the review of the UHC Universal Health Coverage Benefit Package. Mental health will become part of the package to be able to address issues of drug, alcohol, substance abuse.
Yes, maybe the last two, Chemrimir and that colleague, and there was a suggestion, a request from the county that they would like Dr. Kiru, Dr. Amy, Dr. Shen to introduce themselves again, and also Dr. Mary Beth, because they know the DG, they know Dr. Kuria, but they don't know the other panelists. So go ahead.
Yeah, I just said his name is Dr. Kiru, so I'll start with him. The first question is, you've mentioned that we can only conduct testing for Ebola in level 3 laboratories. I'd like to know how many of those we have in the country. I know Dr. Kuria Francis has mentioned that we have adequate emergency centers of operation, but I'd like to know how many level 3 laboratories we have across the country. Second question is to Dr. Francis Kuria about severity of Ebola. Does severity of Ebola also vary, as we saw in COVID-19, depending on one's immunity, perhaps age, underlying conditions, and so on? And the third question is to the DG, Dr. Amoth. Aside from depending on Kenyans in border regions, perhaps the western region, to inform you as the Minister of Health of other Kenyans coming in or other Ugandans coming in through porous borders, do we have measures to instill permanent solutions across the border points, across perhaps closing down the porous borders? Thank you.
Once again, this is Caleb Chemirmir from Kenya Red Cross. Mine is not a question, but just an addition to the comments, especially the emphasis that have been made by the DG as regards the role of the communities in any response, especially Ebola virus disease, if we do have a case in Kenya. Borrowing from experience from other countries and what Red Cross also supported the other Western African nations, one of the most striking or notable issue was the cooperation of the communities. The issue around early detection and early seeking of care at the household level is dependent on the cooperation of the households. And the emphasis that has been put by the DG and even Dr. from UN as regards the community being able to pick the symptoms early enough, but also more importantly, seeking care or reporting in this instance. The challenge being, if you fear as a household member, stay with the symptoms for long, then the chances of survival reduces. But early prompt seeking of care is important for your survival and also for you infecting others. So in the event that we do have a case in your household, do not be stigmatized, do not fear, report early, either of yourself or any other family member that you come from. The challenge that Liberia had, Guinea had, was that there was a lack of cooperation between the communities and the healthcare workers. The reason why, and we do thank the DG for having this session, is that the healthcare workers are ready. The community too should be ready. And as he said, we are all surveillance officers. Thank you.
I thought the lady had a chance. Okay.
Sorry, I forgot one thing. Yeah. So, so far, only one center, the Alupe Referral Hospital in Busia. It is the only one that has been set aside to cater for any case in case it arises. Is it the only one? And what if we experience a case that maybe accidentally it went through the border, now it's in the country? What will happen if we are only depending on Alupe as the only center that has been set aside for the Ebola virus?
So
maybe I can go. Okay, yeah, maybe to answer the question on how I would first of all say that testing of Ebola, the principle and the gold standard is PCR testing. Today we have, during the COVID period, you know very well the way the DG worked very hard to increase the fast testing site from 1 to today over 115. However, although we have over 115 molecular testing labs, Ebola can only be tested in specific labs that have a facility called Negative Pressure Level 3 Laboratory. So this is a very specific and very specialized lab because the negative pressure protects who is outside and the person from aerosols. So out of this, I would guess that we have around 10 level 3 labs, out of which at least 4 are pressurized. And all these labs that are pressurized are actually in Kemri. So the first referral and first stop for any case of Ebola in the beginning of the outbreak, if it will come, will be the Kemri Viral Hemorrhagic Lab, which is WHO accredited. It has a lot of knowledge on viral hemorrhagics, but we are likely to open and also use other labs in CDC Kisumu at Kisian, CDC Nairobi, Walter Reed Lab in Kericho, probably the Wellcome Trust Lab in Kilifi, and also we have a lab in Kemri CMR called the Nuitin Lab. This Nagasaki University lab, which is in collaboration with Kemri, can also be used. But the labs that we know are pressurized are 4, but it's possible to pressurize the others in case many cases will appear. So the basics of testing remain basic PCR. However, the way to handle the samples and also to decontaminate and to archive the samples is different. And therefore, that is why we are saying, if you suspect and you have a molecular testing lab that you have been doing COVID, and there's a suspected Ebola case, do not test it. Because you may not have the negative lab. Just refer. Soon enough, you'll be able to get the contact from the ministry. Just call us. We will have a way of getting that sample and doing the right testing in the right conditions. Thank you.
To build the question on severity, I'll let Dr. Maritim answer that. To the other question on the number of isolation facilities, correction there, Alupe is not the only one. Alupe has been set aside mainly for the border control for now. But the alert that has gone out to all counties that each county has the capacity to set up an isolation center, whatever treatment unit. This, we're only in the alert phase, but the counties have been alerted to be ready to set up quickly and isolate any suspect case. So it's not just Alupe, it is anyone that has managed COVID before can manage Ebola, as long as they issue the correct guidelines and the correct PPE to use in these units. So over to Dr. Maritim.
So your question was very pertinent because in COVID-19, we clearly defined people who are high risk to develop severe illness, critical illness, and likely to die from COVID-19. And we found that these were people with comorbidities, existing comorbidities. However, for Ebola virus disease, any person, regardless of age, gender, race, can actually progress to severe illness. And from the current outbreak, we can clearly see the case fatality rate is 64%, which means of all the people who've so far been identified, 64% of them have since died. When we had the West African outbreak, initially the case fatality rate was very high at the beginning, but as people gain more experience in terms of managing the sick patients, because most of the management is largely supportive, we don't currently have cure for Ebola. There are some treatments that have been tried, including monoclonal antibodies, but they still remain very expensive and not readily available. So in terms of severity of illness, regardless of age, gender, race, color, whatever it is, everyone stands the risk of progressing to severe illness and dying from the disease. So as what was said by our partner from the Red Cross, early presentation to hospital is very, very important, so that the initial supportive management can be initiated, which would include managing the patient, giving them fluids, because if they've passed through the dry phase and have gone to the wet phase, then they're likely to be losing a lot of body fluids, and this need to be replenished, and other symptomatic management. So early presentation to hospital, again, is very, very important, but the risk is very high regardless of the population. So no one, whoever is listening, should think that they will be safe and protected from the disease. Particularly, I know in COVID, the youth have felt that they have been fairly safe, and the risk perception among the youth has been low. But in Ebola, everyone is vulnerable and everyone can die from the disease.
Thank you, Dr. Marybeth. Kirill, I think, had responded to the issue of the porous borders and also lessons learned from 2014 to 2016 outbreak in West Africa. You remember when we closed borders, we closed the international airspace. That did not stop the outbreak. In fact, the outbreak continued unabated until we realized that we needed to have these corridors open to be able to provide the necessary commodities and all the requisite materials required for the outbreak. So, and also look at the economic loss that was suffered. That was mainly not only because of the breakdown in the healthcare system and the general reduction in economic performance, but was also attributed to closure of borders and the international airspace. So if you balance if you balance between closing borders and keeping borders open and focusing on areas that is going to give you dividend, which is event-based surveillance, ensuring that your members of the community are sensitized and moving together as one whole society, you are more likely to reap better dividends than actually closing borders. And I think, as Dr. Kiru mentioned, for example, in Uganda, they have one designated laboratory, and so far that is performing wonderfully. For us, we have 4. So it's not just a question of anybody testing for Ebola because of biosecurity and biosafety. Remember the potential even for bioterrorism. So it's very, very important for us to be able to have this in a controlled manner so that we can be able to ensure safety. For healthcare workers, of course, we are going to send further, based on the case definition and case management, further information. But healthcare workers are actually encouraged to be able to treat any presumptive cases as potentially highly infectious and ensure that they put in place the correct infection prevention control mechanisms. And finally, in addition to what Dr. Kuri had said about designating facilities as isolation or quarantine sites, that is very, very critical so that the other facilities are allowed to continue to offer the routine healthcare services. Remember during COVID-19, when initially, the initial phase, everybody was able to quarantine and isolate. Performance of various health indicators went down because of stigma and people feared going to health facilities for services. Especially like, for example, for pregnant women, the symptoms they are going to present with are also very similar to the symptoms of Ebola. So you can imagine a situation where a mother who is having bleeding, but does not have Ebola, is just having bleeding related to the pregnancy, and everybody runs away from that mother because they fear Ebola. So it's important to be able to have designated facilities for quarantine isolation to ensure that routine services continue in the other facilities uninterrupted. The last question.
My name is Helen Shikanda from the Daily Nation. Has the government set aside any money for preparedness should an outbreak arise? And getting lessons from COVID-19, are there any measures on economic loss should we get infections?
Basically, as a DG, I handle technical matters. I don't handle money matters in the ministry. But we'll come up with a plan, our contingency plan, and we'll forward it to the accounting officer to see areas of support. The government may not be able to have all the resources necessary to be able to contain an outbreak, and that is why we have various partners here. We have Red Cross, we have UNICEF, we have WHO, and therefore global solidarity is very, very key for bringing any outbreak to an end. Regarding any economic stimulus, of course, we'll cross the bridge when we reach it. Potentially that could be considered, because I told you of the economic damage that the 2014-2016 outbreak caused in West Africa. Total combined economic loss of 4.3 billion. And now this coming at a difficult time. As a global community, we are having stagflation, reduced economic performance, increasing inflation, increasing oil prices. We also have a drought situation in the country. So a very difficult time for us, but we believe in global solidarity coming together. As one society, we will be able to overcome. Thank you.
Thank you so much, everyone. So we've come to the end, and before we invite Dr. Emmanuel to give the vote of thanks, please, there was that request from the counties. Introduce yourself, let them know who you are, what you do. Dr. Kiru, Dr. Amy, Dr. Shem, and then finally, Dr. Mary Beth.
So, my name is Dr. John Cairo. I head the Department of Lab Services at the Ministry. I believe I'm not new to the counties because we've done very well on COVID-19. Definitely, maybe they know, but the moment they hear the name, they'll be able to know. Because I think COVID-19 was an exemplar disease, and it has actually brought the ministry very close to the counties. Thank you very much.
Thank you. My name is Dr. Amy Herman-Roloff, and I'm the Acting Country Director with the U.S. Centers for Disease Control and Prevention based here in Nairobi.
My name is Shem Kipton. I work with WHO. I oversee the subnational health systems and also help with epidemic preparedness and response.
My name is Dr. Mary Beth Maritim. I'm an infectious disease specialist and senior lecturer at the University of Nairobi, Department of Clinical Medicine and Therapeutics.
So with that, thank you so much. Allow me now to invite from the county. They said they know Dr. Kuria, they know the DGs, but there is no harm, Dr. Brigadier, if you introduce yourself to them. Yes.
I'm sure they know me. My name is Dr. Francis Kuria. I come by other titles, Brigadier Dr. Francis Kuria. I only came into the ministry from the Ministry of Defense. Happy to work with the Ministry of Health during COVID response and now managing all the other COVID pandemics. And I'm sure I've interacted with all the counties, all the partners here through the task force and through the COVID response. And we are still there. And maybe a parting shot, I think the media houses, I've always applauded them for what they do for us. We worked through the COVID response and spread messages quite well. We call them our big brothers. And for this, the question I've been asking, do we have a case of Ebola in the country? The DG has said it, we do not. But as is pointed out here earlier, the incubation period is quite long. We will not tell you we don't have until we are sure we don't have. It may have seeped through. The question is not if we have or when we have it, but if we have it, what shall we do? And that is why we are here. Thank you.
So from my end, before I invite Dr. Emmanuel, please join me with a round of applause to really appreciate the panelists. The last one again, please, a round of applause to the panelists. Thank you so much. So let me hand over to Dr. Emmanuel. My name is Hilary Limo. Thank you, Dr. Emmanuel. Maybe you can please resume kindly. Thank you so much. Thank you so much. Right. So after Dr. Emmanuel, I think we'll have a prayer from Nasoro. Yes, Dr. Emmanuel.
So good morning, colleagues again. Allow us to bring this meeting to an end with this short vote of thanks. The DG, we most sincerely thank you for convening this meeting. I think our media colleagues are now at peace with the ministry. we've given you information. Also allow me to thank our Director of Public Health, Dr. Francis Kuria, our Head of Department, Dr. Langat, our National Technical Staff, the counties that are on virtual mode. Maybe we did not alert you. All our counties are on the call virtually. We also want to thank our development partners, including WHO, CDC Kenya. We also have University of Nairobi, Red Cross, CDC, and anybody else I may be missing. We most sincerely thank the media again, as indicated by the panelists. You are a major stakeholder in this preparedness and subsequent response activities, and we'll be inviting you to the risk communication subcommittees. Our contact person is Mr. Wycliffe Martini. Maybe you can stand up, Mr. Martini. Is our contact person for the ministry who will be coordinating us, and Emily Bade, and we have Mr. Mutua Martin. So anytime you want to get information from the ministry and the response team, those will be our main persons. We also must sincerely thank the hotel for hosting us at a very short notice, and I think they've served us well. Asanteni sana. And finally, allow us to most sincerely again thank we want to thank AMREF for supporting this meeting again at a very short notice. So asanteni sana AMREF. And before we close, we're also requesting that we'll have a group photo outside the hotel. So good morning and have a good day. Asanteni sana.
So we'll close our meeting by praying. So we'll recite Surah Al-Fatiha. So A'udhu Billahi Minash Shaitan Rajim. Bismillahir Rahmanir Rahim. Alhamdulillahi Rabbil Alamin. Ar-Rahman Rahim. Maliki Yawmiddin. Iyyaka na'budu wa iyyaka nasta'in. Ihdina Siratal Mustaqim. Siratal Ladina An'amta Alaihim. Ghayril Maghdubi Alaihim Waladdallin. Amin. Amin. Thank you.